the foundation, we advocate, educate, and innovate to improve access to healthcare in the United States and globally. So we recently, a couple of years ago, established 25-bed cancer hospital in one of the provinces in Nepal. In fact, this was the first charity cancer hospital outside the province 3. So right now we are working on expanding this cancer center to 200-bed cancer hospital, equipped with everything, including next generation sequencing. So a lot of work being done in that front. We developed our own electronic medical record. So essentially, everybody who comes to our hospital, it's entered in the EMR. We don't have certain complexities, such as insurance issues and meaningful use and all that. But doctors can write notes, they can input labs, you can upload documents, and vitals, ins and outs, and tumor board recommendations. Everything can be placed right there. And we have weekly tumor board. In fact, except for this molecular tumor board, we have weekly tumor board where the doctors in Nepal present their cases, and some of the national leaders, including from Sloan Kettering, from tons of people from Seattle area, as well as from other institutions in the country, they join us and we talk about cases and help make recommendations. We also partner with Government of India and helped establish hospice and palliative care programs in the state of Madhya Pradesh. And it was one of our major initiatives there. In Nepal, we partner with the hospital, government hospital, and established Nepal's only bone marrow transplant center. And that does everything, including autologous, allogeneic, and haplo. And this is one of our major projects that was successful. They have been pretty good success rate. They have published in Lancet, in the British Journal of Hematology, and a bunch of other medical journals. And we organize some of the major cancer conferences, not only in Pacific Northwest, but nationally. In fact, our cancer health disparity, the meeting is one of the major national cancer disparity conference, where some of the national leaders, including ASCO president, ASH president, and lawmakers, patient advocates, president of Fred Hutch, SCCA, Nancy Davidson, and all those folks that join us. Not only we talk about what the disparities is right now in cancer care, but we also talk about how we can improve, implement innovative methods to improve access to care. And of course, we organize the largest ASCO review in Pacific Northwest. We also do ASH review. So a bunch of major conferences we do. ASH review is coming up in December, and some of the national leaders, including Dr. J.D. Radish from Fred Hutch, Dr. Shaji Kumar from Mayo Clinic, Dr. John Leonard from Cornell, and a bunch of others would be joining us for this meeting. It would be a great conference. And this is our board members. We have, besides me and Tara, we have Tim Erickson from Dana-Farber, Yusuf from Michigan, Darrell Walker from Boise, Julie from SCCA, Seattle Cancer Care Alliance, David from Virginia Mason, and Bipul, he's out of Texas, and he's our Chief Technology Officer. And we have outstanding interns who do a fabulous job in helping us achieve our goals. So these are some of the things we do. Now, we recently established one Cancer Research Institute, and our goal is to create something like Fred Hutch, and some of the national leaders, including a bunch of doctors from Mayo Clinic, Dana-Farber, Fred Hutch, all over the country, they are part of that. So our focus is very different compared to Fred Hutch. So we would not be doing any basic science research. In fact, we collaborate with Fred Hutch all the time. They have been great partners. So our focus is primarily on cancer disparity. So how to improve access to care nationally as well as globally. That's what we are working on. So with this, I would like to invite Sonia to, she has 4 minutes. She is sponsoring this the meeting today. Sonia.
Yeah, thank you, Dr. Shah. Your foundation is so special. It's really wonderful how you've, I guess, evolved through the years and what you've been involved with. It's really exciting. So thank you for inviting us to be here. I appreciate that very much.
Thank you, Sonia.
Get started. So I work for a small little biotech based in Boston called Acceleron. I'm actually based here in Washington, but I just want to give you a little bit of a brief overview of Reblozyl. It's the first and only red blood cell maturation agent. And I'm going to cover just a few things. I have about 3-4 minutes, and we'll cover how it works, the primary endpoints of a phase 3 trial, and a little bit of safety information as well. So it is a red blood cell maturation agent. It's not an ESA. It's indicated for the treatment of anemia failing an ESA requiring 2 or more red blood cell units over 8 weeks in adult patients with very low to intermediate risk MDS with ring sideroblasts and MDS, MPN, RST. It's not indicated for the immediate correction of anemia. And I'm going to skip through a few slides since we have just a short amount of time. So just a little bit of how it works. As we all know, ESAs work in this earlier phase here. MDS, a lot of these patients do require transfusions, and a lot of these patients do have increased SMAD2/3 signaling, which then inhibits their late-stage erythroid cells from becoming an actual red blood cell. When you look at how Reblozyl works, it actually restores erythropoiesis by increasing the number and improving the quality of the red blood cells. It actually binds to several TGF-beta superfamily ligands, which then diminish the SMAD2 signaling and allows those red blood cells to become actual red blood cells. So a little bit how it works in the trial that was done. Reblozyl was studied in a multi-center randomized, double-blind, placebo-controlled phase 3 trial called the Medalist trial. The primary endpoint of this trial was red blood cell transfusion independence of 8 or more weeks during the first 24 weeks of the trial. Reblozyl did achieve this endpoint. In fact, 37.9% of Reblozyl patients versus 13.2% of placebo patients did achieve this endpoint. Also of note, 80.4% achieved this endpoint if their baseline red blood cell transfusion burden was 2 to 3 units during an 8-week period of time. Now briefly, just to cover off on some safety information as well, the median time on treatment was 50.4 weeks, so a good chunk of time. There are 3 warnings and precautions: thrombosis in beta thalassemia patients in 3.6% of patients, hypertension in 10.7% of patients, and there was some embryo-fetal toxicity as well. The most common grade 3 adverse reactions included fatigue, hypertension, syncope, and musculoskeletal pain. And as you can see on these 2 slides, this one here, along with the second one, many of these adverse reactions were mild to moderate. Lastly, you can see in this graph, there was a change in treatment emergent adverse events the longer patients stayed on the drug. Just a quick reminder, Reblozyl is a sub-Q injection. It's given every 3 weeks. Reblozyl does have a permanent J-code. Just wanted to thank you again for your time, Dr. Shah. Feel free to reach out to me or any of my Bristol Myers counterparts if you have any questions or concerns.
Sonia, thank you.
Thank you.
All right, Sid, back to you. Sid, can you hear me?
Yep, sorry, I was on mute.
Okay. Yes, okay.
So let me share my screen and then I think we can get it started. Okay, I think this should work. Okay. Can you see my screen?
Yes.
Perfect. Good morning, everybody. We have an exciting session on ovarian cancer today. So let me start by introducing the panel that we have today. So my name is Siddhartha Yadav. I'm an assistant professor of medical oncology at Mayo Clinic. I primarily work in women's cancer program and primarily take care of patients with breast and or ovarian cancer. Joining us today, we have president of the Binaytara Foundation, Dr. Binay Shah. I don't think he needs any introduction. Welcome, Dr. Shah. Joining us again from, we had Dr. Fengting Yan join us last time for the breast cancer session, and she's back here again for the ovarian cancer session. She is a medical oncologist at Swedish Medical Group, and with significant interest in personalized care and translation research in women's cancer. Thank you, Dr. Yan. Next, we have Dr. Charles Drescher. He is a clinical professor of OBGYN at the University of Washington School of Medicine. He's a professor in Public Health Sciences Division at Fred Hutch and a practicing GYN oncologist and surgeon at the Fred Hutch. He's a well-known expert in the area of discovery of molecular targets for ovarian cancer prognosis and therapy. And finally, joining us from India is Dr. Shona Nag. She's a director of oncology at the Sahyadri Group of hospitals in Pune. She has been a champion of treatment of breast, ovarian, and cervical cancer in India for more than 2 decades now. Thank you for joining all of you. Thanks to the panel. So with that, let's move on to what we're going to talk about today. We're going to talk a little bit about epidemiology of ovarian cancer in the United States. We'll discuss some common molecular abnormalities in ovarian cancer and its implication on management. And then we'll talk, I think, quite a bit about germline genetic testing in ovarian cancer and outline the role of PARP inhibitors in management of ovarian cancer. Because this is really the area where a lot of changes have happened over the last decade or so in terms of treatment. So going briefly over ovarian cancer introduction in the United States, estimated new cases, there are approximately around 20,000 or so new cases. If you look at all different types of cancer cases, it constitutes around 1.2%. However, if you look at the deaths, there are approximately 13,000 deaths in the United States from ovarian cancer every year, and that accounts for around 2.3% of all cancer deaths. 5-year survival for ovarian cancer is 48.6%. It's not a whole lot, not quite good. If you look at age distribution of ovarian cancer, it's primarily a disease of older women, and 63 is kind of the median age for ovarian cancer. So a significant proportion of women are over the age of 63, or so more than 50% are over the age of 60. When you look at the stage-wise diagnosis and outcomes, and I think this is important in terms of when we think of a screening, there are no great screening tools for ovarian cancer, and that is reflected in the stage at which patients are diagnosed. So localized ovarian cancer is diagnosed in only 16% of women, whereas if you look at the majority of women are diagnosed with distant disease. And if you look at the outcomes based on the stage at diagnosis, relative survival for localized disease is 92.6% 5-year relative survival, whereas for distant disease, it drops down to dismal 30.2%. So with that in mind, let's move on to our first case. So this is a 44-year-old female, no significant past medical history. She does have a family history of prostate cancer in maternal uncle. In paternal uncle, she wasn't quite sure whether that was metastatic or not. It wasn't quite known. She is Asian and she's from Philippines. The ovarian cancer mass was noted during hysterectomy for uterine fibroids. So she was having some abnormal bleeding. So on ultrasound, it was noted that she had fibroids, and they went in to do a hysterectomy when they noted that there was ovarian mass. She underwent bilateral salpingo oophorectomy omentectomy, pelvic lymphadenectomy, along with hysterectomy as well. And it was noted that she had bilateral high-grade ovarian serous adenocarcinoma with negative omentectomy and pelvic node. However, peritoneal washing was positive for malignancy. So this was staged as 1C3, and then she received 6 cycles of carboplatin and paclitaxel. So this is where I want to bring in the panel a little bit and talk about, in early stage ovarian cancer, so patients who are diagnosed with stage 1 to 2 ovarian cancer. So typically, the way I think of chemotherapy is if somebody is stage 1C or higher, if they have clear cell histology, or if they have high-grade tumor, and grade is, I think, an important factor in ovarian cancer, then I tend to think of administering chemotherapy. But I would like to bring in the panel and talk a little bit about, from the panel's perspective. Let me go to Dr. Charles Drescher first and see what his thoughts are in terms of adjuvant therapy for stage 1 to 2 ovarian cancer.
Yeah, terrific. I certainly agree with your comments in general. There are a few nuances, though, that I think need to be considered. With respect to stage 2, I think certainly all those patients require adjuvant therapy. In the stage 1 group, the high risk features that you identify here are very much kind of the traditional features for which one would consider adjuvant therapy. Perhaps the clear cell histology is a little bit more controversial. There's not any randomized data, but there's certainly been several institutional series which have suggested for patients who have stage 1 clear cell cancer that chemotherapy may not be beneficial. And the current NCCN guideline recommendations include the option of observation for patients who have early stage clear cell cancer. I think the other issue where there's room for consideration is actually in the number of cycles of treatment. Again, focusing primarily on the stage 1 cancers for which you would consider chemotherapy. There was a randomized trial, as I'm sure you're aware, that compared 6 versus 3 cycles of chemotherapy, which included predominantly stage 1, all histologies. And that trial actually did not, in an overall analysis, show benefit to 6 cycles versus 3 cycles of chemotherapy. But in a subsequent subgroup analysis, there was improvement in the serous histologic subtype. So I think, the conventional standards is for 6 cycles of chemotherapy for early stage high-grade serous. There's certainly room for fewer cycles, perhaps 3 for patients in the non-serous histology group.
Perfect. Thank you, Dr. Drescher. So considering that this patient did have high-grade serous, you would go with 6 cycles of carbotaxol rather than 3 in this case. Is that correct?
Yes, exactly.
Okay, sounds good. So we'll move on to Dr. Yan. Any further comments on chemotherapy recommendations for stage 1 to 2 ovarian cancer?
Yeah, I totally agree with Dr. Drescher. And actually, I'm the medical oncologist, and typically those actually relatively early stage patients, most of the time actually, they will stay with Dr. Drescher. They don't necessarily have to see a medical oncologist. So I know Mayo Clinic, all the chemotherapy is by medical oncologists, but this is kind of different scenario, different situation. So in most of the practice, actually, if they had surgery by Dr. Drescher and if 6 cycles of carboplatin, and most of the patient actually will stay with GynOnc and have that. But I totally agree, and occasionally I do have those patients too that I did the first consultation, they'll come back to me for the chemotherapy. But I totally agree that 6 cycles of carboplatin would be the standard of care. The nuance though is recently circulating tumor DNA is getting our attention again. I know we have been talking about that for a long time, and we don't have good data in ovarian cancer yet, but the data is kind of similar in colon cancer, that when we were debating 3 months of adjuvant chemotherapy or 6 months of adjuvant chemotherapy, and actually circulating tumor DNA were very important, actually helping us make a decision. So we are actually working on clinical trials using circulating tumor DNA to help us make decisions, and hopefully that will be the direction for ovarian cancer too.
Thank you, Dr. Yan. So Dr. Nag, any further comments on chemotherapy for stage 1 to 2 high-grade ovarian cancer?
No, the only other thing I have to add is that in my practice, I don't see much of stage 1 and stage 2. They make up barely 10 to 15% of my patients. And I absolutely agree that if I get such a situation, I would prefer to give 6 cycles of Taxol carboplatin.
Perfect, thank you. Dr. Yan, since you brought up the circulating tumor DNA, I think that's very fascinating. I just want to, for our audience, just want to clarify what circulating tumor DNA is. This is basically, you're looking for tumor cells in the blood. So you're doing blood based testing and trying to look for tumor cells in the blood. And it has been shown to be prognostic in several cancers. I think maybe just we could spend a couple of minutes on circulating tumor DNA since we are not going to cover that today. Dr. Drescher, is this something that you would use today outside of clinical trials, or is it not ready for clinical practice yet?
Yeah, great question. I don't think there's any data at the moment with respect to circulating tumor DNA in sort of standard clinical practice. There have been a number of studies sort of looking at this. And I also want to make the case, it's not actually just simply looking for circulating tumor cells. It's also encompasses DNA, so cell-free DNA that might be in circulation, because one of the mechanisms for release is potentially tumor cell necrosis and then subsequent release of DNA into circulation. Just in general, for ovarian cancer, the number of patients and the amount of circulating DNA it tends to be lower for ovarian cancer than some of the other cancers, and most conspicuously colon cancer. We actually have a project ongoing focusing on advanced stage cancer using ultrasensitive methods for DNA detection, kind of beyond what most of the sort of current sort of next gen profiles do, in the hope that the sensitivity will improve. But one of the so it's not available clinically. I wouldn't recommend it ordering an assay and trying to use it to guide clinical decision making. It's definitely a research tool. And one of the, I think, challenges has been relative to other cancers, the actual number of cancers and the number of tumors and the amount of DNA that's detectable in circulation is relatively lower. So we have to develop technologies that will kind of overcome that limitation.
Thank you, Dr. Drescher. So moving on, so obviously—
Can I interrupt for a second, Sid?
Sure.
So in case somebody has question, please type that in the chat area, and Dr. Siddhartha Yadav and other panelists will take the questions. So please feel free to type your questions anytime you wish. Thank you.
Perfect. Thank you, Dr. Shah. So moving on to this case, then we have a high-grade serous stage 1C ovarian cancer who underwent surgical resection, received 6 cycles of chemotherapy. What is next for this patient? And I just throw out, is there any role of maintenance therapy? And typically we're talking about PARP inhibitors over here in early stage ovarian cancer. And does that, is there any data to say that it improves outcomes? Or would you recommend surveillance for all of these cases? And obviously I throw in genetic testing in there. And how do you approach genetic testing in these cases as well? So I'll start with Dr. Yan at this time.
Yeah, we if a patient comes to see me and if it's ovarian cancer, we always encourage them to have genetic test.
Would you do any maintenance PARP inhibitor in this situation? Is there any role for maintenance PARP inhibitor in this situation?
No, if the patient does not have any new BRCA mutation or HRD, that's no proven benefit because this is frontline, is first treatment. So unless the patient has BRCA or HRD.
Dr. Drescher, your thoughts on this?
Yeah, just a couple thoughts. Well, I don't think there's any role for maintenance therapy in early stage cancers. Because their baseline recurrence rate is much lower than patients with advanced stage, that sort of whole equation about risk benefit is shifted. The patients who are known germline mutation carriers, that's that's definitely a kind of an enigma. We just don't have any data about the relative risks and benefits in that particular population. So all of the PARP maintenance studies after first-line therapy were focused on patients with advanced disease. And it's a little, one might be inclined, but I think it's a little bit premature to translate that data into early stage patients. Again, just because the baseline recurrence risk is much lower. And as you know, there are, toxicities and problems associated with PARPs that, need to be considered. I certainly agree that all patients who are diagnosed with ovarian cancer need to be referred for genetic counseling and genetic testing. Our approach in the early stage patient, I think mostly because we just don't have access to tissue quite as readily, is to refer them to take the approach of using a germline approach first as opposed to somatic testing. And yeah.
Perfect, thank you. Dr. Nag, what is the availability of PARP inhibitors in India and again in this situation, and also genetic testing? I mean, could you clarify that a little bit for our audience?
So things have come along quite a bit, and this sort of patient in our practice, high-grade serous, would definitely go in for genetic testing. And as a doctor mentioned earlier, that all the studies for maintenance PARP have been stage 3 and 4, and this patient has a survival between 85 and 90% at 5 years. So PARP olaparib actually became available in India about 6 months ago, but before that we were able to use it on a compassionate-based program. So I was able to use it at least in like 3 or 4 patients for platinum-sensitive maintenance and monotherapy. And now we've started using it as it's become locally available for first-line maintenance as well. So yes, that's available. Genetic testing is an issue, but we have some super labs all across the country which are accredited. There's some in Bangalore, they're in Bombay, they're in Delhi, and we have one in Pune as well with super NGS facilities. The problem is the availability of genetic counselors. So I don't know why, there's people are not going in to become genetic counselors, and they're not really available. In the whole country, we may have about 25 trained genetic counselors. So the medical oncologist does a lot of the counseling, or we do it online with a renowned lab that gives us the service of a counselor. And then we do the pre-test counseling, go through the testing, and finally a post-test. So that's how things are done here right now.
Thank you.
Could I ask a question? Do you have any sense of what proportion of your ovarian cancer patients overall get genetic testing?
So we did a little study. So we've had 155 patients referred to the genetic clinic in the last 18 months, out of which 80 satisfied the HbA1c criteria. Out of these 80, almost 52 patients did come up for genetic testing.
Oh,
and the uptake is good if you spend time. And the pre-test counseling may not be one meeting. It may be about 2 or 3 meetings, because it's a family issue. They're very concerned about their own results. They're very concerned about what impact it's going to have on the rest of the family. So yeah, it takes some time, but we usually get them in for testing.
Yeah.
Yes.
Well,
Sorry. Can I ask how much would that be in India to have a genetic test?
So it's become so reasonable now because of homegrown NGS experts and machines that a HPOC panel, which would comprise of about 37 different genes, would cost 20,000 rupees, which would be $300 US.
Or probably even
Is
less,
it,
like a 200 or probably.
I see. Is it,
Yeah, about
is it
200, 250.
I see. Is it affordable to most of the families and patients?
So see, there is a big middle class coming up, and there's a lot of insurance now, which also accepts genetic testing, especially because the PARPs have come in. So we kind of get it in through insurance. But yeah, patients can be motivated to do it.
Oh, that's great.
Yeah.
Just to highlight, just neighboring country in Nepal, where Binaytara Foundation and we do a lot of our work, we don't have any germline genetic testing facilities yet. But I think that is something, and we have to send our samples to India, which is a huge hurdle to genetic testing right now. And from a cost perspective, everything, it's a huge challenge. But it is something that I think Binaytara Foundation is trying to work and trying to correct that.
Yeah. This is Dilip. This is an exciting discussion because a few months back, we were looking at building this genetic counseling platform, and NCI is actually has recognized as one of the barriers to increase precision medicine in the US itself. But if there is a uptake in developing country and $300 price, I think in 18 months time frame, it will come down. So we would like to have a discussion, not today but somehow, that we can build the facility in terms of counseling outside US, but make it available at a very cost-effective manner. Because more people go for it, I think the cost will go down, and this is the promise, So we have an opportunity to take it to large numbers of people in developing country. And the cost point, the $300 36 gene panel, I think we can squeeze this down. But if we can use our collective knowledge, because this is an evolving field, what actually works and which marker, and one of the very fascinating thing is that the genomic diversity is so much. So what we see in India may not be what we see in US. So creating a knowledge which moves with each interaction we have, that will be huge. And we did some groundwork, and we were about to put a proposal, but we didn't have the enough oncology input in our team, so we let it go. But I would like to have a discussion. This is what we can make a very compelling solution. Our cost point is that below $100 we can provide a counseling, which is very state of the art, and by collaborating and having focus on global communities, I mean we can make a real contribution here.
Great points. Dr. Shah, just quick comment on that, and then we can move on to with the case.
Yeah, so there is a question by Dr. Ramesh Drescher. Would you like to take that?
I'm not sure if I can see the chat when I'm sharing my screen. Let me see if I can do this.
Go down next to participants chat.
Let me see. Chat, yeah, okay. All right, Dr. Ramesh Drescher asks, is it good to counsel the patients for PARP inhibitor maintenance in advanced or also in early disease, like 1C disease if she has BRCA1 or HRD positive? I think we'll come to this question just in a little bit, because I think and I think Dr. Drescher already addressed this, is in early stage disease, there isn't data, even if you're BRCA positive or HRD positive, to use PARP inhibitors. But we'll come down to at the end about this a little bit again. So just hold on to that thought for a little bit. Okay. So moving on, let's talk about approach to germline genetic testing in ovarian cancer. And So, when we think of stage any ovarian cancer, I think germline genetic testing, I think most of our panelists would agree that germline genetic testing would be indicated in this case. The question that really sometimes comes up is, do you only do BRCA1 or 2, BRCA1 and 2, or do you do multi-gene panel testing? Obviously, 10 years ago, multi-gene panel testing was much more expensive, not readily available, and there was much more push for just doing BRCA1 and 2. And I think that has changed over the years. But we'll come back to that thought in just a little bit after we review this data. So this is one of our studies that we did in combination with one of the genetic testing laboratory in the United States. We had roughly 12,000 ovarian cases that we looked at. And if you look at, between breast, endometrial, colorectal, pancreatic cancer, you do see that ovarian cancer does have quite high rates of germline mutations. So if you look at it, it almost approaches around 15% or so. But a bulk of all of this, the green in this is BRCA1 and 2 mutations. So almost roughly 7 to 8% is BRCA1, 2 mutation carriers. Whereas the blue is other hereditary breast ovarian cancer genes, and that constitutes roughly around another 5% or so. And then you have Lynch syndrome genes, which could be are associated with increased risk of ovarian cancer, especially the endometrioid types. And then you have some other genes, cancer predisposition genes, which constitute very small proportion. I think just briefly touching on what are the genes that are associated with ovarian cancer risk. And I think this is again from the same study where we looked at the frequency of germline mutations in ovarian cancer patients and compared that to frequency of germline mutations in general population using the NOMAD control data set. And what we found was BRCA1 and 2, if you look at the odds ratio is almost more than tenfold. And for events like a germline mutation, which are rare, you could pretty much translate the odds ratios to risk ratios. And so what that really means is if you're a BRCA1 or 2 carrier, your risk of developing breast cancer is probably roughly around tenfold higher than the general population. We also found that BRIP1 is also associated with increased risk. And if you look at RAD51C, RAD51D, TP53, those are also genes that are associated with increased risk of ovarian cancer. Some of the Lynch syndrome genes as well, MSH2, MSH6. So it's not just BRCA1 and 2, but it is also some of these other genes that are associated with increased risk of ovarian cancer. Now, the NCCN guidelines, if you look at that, it's all women with a personal or family history of ovarian cancer. Now, the family history of ovarian cancer is if the family member cannot undergo testing, that's when you bring in that's when somebody who has a family history should also be offered genetic testing. And so I think this is something that the panel had highlighted earlier. Couple of quick comments on, before I move on to the next slide, just want to bring in a little bit about the question on multi-gene panel testing versus BRCA1 and 2 testing. I think Dr. Nag, you had mentioned earlier that you do a 30-something gene panels. Do you have BRCA1, 2 only available? Is it cheaper to do that only? And are there cases where you would consider doing BRCA1, 2 only versus multi-gene panel testing?
So that's a very valid question. The first 6 months I was only doing BRCA1 and 2, but it cost 15,000 rupees. And then this panel came in for 20,000. I realized that, although it's mainly BRCA1 and 2 we are looking for, there are other high penetrant genes. And we shouldn't be ignoring them because there are certain guidelines, at least for some of the high penetrant ones, which we may use. And besides, it was efficient, cost effective, and cheaper to do than a cascade testing. So we kind of shifted over to panel after some time because it was really cost effective.
Dr. Yan, what do you do in your practice? Going by starting with BRCA1, 2 and then cascading to panel, or do you just go with the panel directly?
We always do the multi-gene panel unless the insurance doesn't cover, but almost everyone get covered. So almost everyone get some sort of, we do have quite a few different companies who run the test, but we always do a multi-gene panel.
Dr. Drescher, is there anybody where you would consider just doing BRCA1 and 2, or have everything moved towards multi-gene panel at this point?
Well, I think there is potentially a role for targeted gene testing in someone who's a family member of a known mutation carrier, where that's the single most likely abnormality.
Yeah.
But outside of that, the standard approach, again, depending a bit upon insurance, is to go to the multi-panel testing. I think the only caveat to that is you just have to be very clear with the patient that there's a much higher risk of turning up a VUS.
Absolutely.
And that they just need to be informed about the relative lack of significance of that. But that is a conversation that I think needs to be explained up front.
Great point. Yeah, more is not always better. The higher number of genes that you test, the higher chance that you will end up with a VUS, which is variant of uncertain significance or indeterminate result. And typically they are treated as you do not act on those results. But there are quite a few case reports now where the people have acted on VUS results, and that led to doing aggressive surgeries. So you definitely don't want to be one of the surgeons or medical oncologists who is featured in those case reports. So.
Yeah, right, exactly.
So moving on to the NCCN guidelines, all women with a personal or family history of ovarian cancer, again, if you cannot test the proband, then it should be offered germline genetic testing. But this was very interesting to me. This is looking at from Dr. Kurian at Stanford, who looked at the SEER data set and matched the SEER data set with the germline genetic testing from major labs in the country. And what she found was uptake of genetic testing among women with ovarian cancer. If you look at it overall, was only 1/3. So all of these women should have been referred for genetic testing and should have undergone genetic testing in many ways, but only 31% of women really underwent genetic testing. If you look at Black women, that number drops down to 22%. And I think there is a huge disparity even within the United States. The question is it really an issue of lack of counselors? Is it really an issue of a lack of access, insurance? Or what is really driving this low uptake? And I think I want to talk a little bit about this with the panel and see what your thoughts are. Dr. Drescher, I'll go to you first.
Yeah. Well, first of all, I think the shocking thing is how low the overall uptake is to begin with. And these results, I think, are not extraordinary. I think there's been many studies at many excellent centers where the uptake is way less than what you would expect. And that's why I was so surprised and kind of congratulatory based on the experience in Nepal. This issue about race, I think, is the lower uptake among Black women. I was just at a meeting talking about health disparities and suggesting that the issues around race, for most, not all, but for many aspects which relate to cancer care, is not so much associated with like biology, but much more related to socioeconomic status and access. So while I don't think we have specific data about this in ovarian cancer, my suspicion is that this is much more sort of an access to care issue. And I suspect if you looked at all aspects of these women's ovarian cancer care, it would, beyond the genetic testing uptake, it would unfortunately be more likely to fall below standards.
Any further comments from Dr. Nag or Dr. Yan at this point on this?
Yeah, I would agree. It's surprising lower than I expected. And I think in general, it's more if it's covered by insurance and if it's available for the patients. But it's actually lower than I was expecting.
I guess one comment, if I could. I don't recall, I've seen the study, but I don't recall the time interval. And one thing that, if you look at a time series, there is a pretty substantial increase in the more recent years.
Yes, and I think we would expect that that there would be, I think this study looked at the SEER data set, which was 3 or 4 years prior to the publication. So SEER cutoff was like probably 2015 or 2016, something like that. So yeah. I think hopefully we're doing better in recent years. So moving on, this patient did undergo, this is one of my patients at Mayo Clinic, this patient did undergo germline genetic testing, and we did find a BRCA1 mutation. So I would go back to the question that Dr. Ramesh Drescher had asked earlier. Now knowing that this patient is BRCA1 mutation, would you change your thought about maintenance at all? Or would you still say no maintenance? And obviously there are implications for breast cancer management and other things, breast cancer screening and other things, but from an ovarian cancer perspective, does your thought process change at all for PARP inhibitors? I'll go to Dr. Nag first.
No, I don't think I would change my stance on offering her PARP. She's an early stage. I would certainly, as you mentioned, be very concerned about her breast cancer risk. And that is really high. So that would need to be handled, although bilateral salpingo-oophorectomy does give a 30% protection against breast cancer. That's not nearly enough. So she would have to be under intense surveillance or be offered a prophylactic surgery. But I would not put her on PARP inhibitors.
Thank you. Dr. Drescher?
Yeah, I agree. It's a pretty intriguing question, and I appreciate the thought that would have to go into this, but there really isn't any data. Her prognosis is generally good. The data that we have for PARP inhibition in advanced stages focused on PFS, and we don't really have any mature survival data. So I don't think you could turn to this woman and tell her going on a PARP is likely to increase her chance of cure. So for those reasons, I would not offer PARP.
Perfect. Thank you, Dr. Drescher. And I think an important point that you had brought up earlier was also the toxicity. I mean, there is almost a 5% risk of myelodysplastic syndromes with PARPs. And in this case, women, I mean, who has a very low risk of recurrence, I mean, how long do you even go? The duration would be a question as well. Dr. Yan, any other thoughts on this?
Yeah, I agree. PARP inhibitor sounds very cool, and I had many patients ask me that. But if you come to the reality, and quite some patients had side effects and cannot even tolerate. So if a woman is not benefiting from that, I will not harm the patients. So early stage, I don't think we have any good data, and for advanced stage, we want to make sure we have a good discussion and make sure that was discussed. But for early stage, I think the benefit is unknown, and it's actually causing harm.
So I think we have a question from Dr. Rosales is, knowing that this patient is BRCA1 positive, does that change your surveillance at all? What kind of surveillance would be appropriate for this patient? And does the BRCA positive change your surveillance for ovarian cancer recurrence? I guess that's what Dr. Rosales is asking. So Dr. Drescher or Dr. Nag, do you want to answer that? Or Dr. Yan, anybody could?
No, except for the breast part. Yeah, the women would need breast surveillance, the high-risk surveillance, and depending on the age and depending on the scenario, so the breast need to be taken care of.
But you would not change the ovarian cancer surveillance?
No, not really.
Okay, Dr. Drescher or Dr. Nag, do you agree with that?
Yep.
Yeah, I would agree. I just would. So our typical surveillance in a situation like this would be to see the patient quarterly for the first 2 years, and then semi-annually. And as part of that would include, assessment of symptoms, a clinical exam, and a CA-125 or HE4, more commonly CA-125 biomarker, and not do routine imaging, but instead use imaging, more as a second line test to follow up on any type of sort of suspicious abnormalities. The one area where I think there's a little uncertainty is how long to continue that surveillance. Traditionally we think of 5 years because honestly for most advanced stage cancers, if they're going to recur, what we would generally, although things are changing, detect a recurrence within that first 5 years. But I think for these early stage cases, the recurrence risk could span much longer. And I think there's no data, but at least a rationale to continue extended surveillance beyond 5 years.
Perfect, thank you. So moving on in the interest of time, let's go to our second case. So this is a 64-year-old female who presents with abdominal pain, ascites, and is noted to have undergo CT scan, noted to have several peritoneal implants, and at least one of them is more than 2 centimeters. CA-125 is 150. There are no other lungs, liver, bones metastasis, so it's primarily confined to the abdomen. Biopsy of a peritoneal nodule does confirm a high-grade serous adenocarcinoma. She does undergo a debulking surgery, and they are able to get all the macroscopic disease out, so down to R0. And then she received 6 cycles of carbopaclitaxel with bevacizumab. CT scan was completed after a chemotherapy of 6 cycles, and it did not demonstrate any evidence of disease, and CA-125 is 9. She does undergo germline genetic testing using multi-gene panel, and that is negative. So the question, so this is this is a stage 3C ovarian cancer, who has undergone upfront debulking and has undergone chemotherapy now. She has completed chemotherapy with carboplatin, paclitaxel, and bev. And so the question here is maintenance therapy. And maintenance therapy in terms of, do you just do bev? Or do you do bevacizumab with PARP? Do you do PARP alone? Or do you just choose surveillance? And so let's talk about that a little bit. And let's start with Dr. Nag this time.
So this is very uncharted waters for me. We do use bev in our country. It's been available for a very long time. The lady's done reasonably well on bevacizumab. I would definitely continue bev. The question is, with the new data out there, would I switch to something like niraparib given the PRIMA trial results? Or would I add olaparib looking at the PAOLA-1 results? So that's something I think we need to discuss out, and I would take this patient to my MDT. And if keen on something more than bev, I would probably ask for a HRD testing. It's not available in our country yet, but I'm sure it is in the US, and maybe that's what you do. I don't know.
Dr. Drescher, so I think this is the question that I think is being posed over here is, you could do a bev PARP inhibitor, and you use basically a biomarker-based strategy to decide on maintenance with PARP, so either looking at BRCA1/2 or HRD testing, or do you do maintenance irrespective of biomarker-based, irrespective of what the biomarker comes out to be? And what is your practice, and how do you approach this advanced ovarian cancer upfront PARP maintenance?
Right. Yeah, and in this particular case is of course also complicated by the fact that she's started on bev, which is sort of another layer of complexity. But I think in someone, who's just receiving upfront carboplatin paclitaxel, has evidence of a response to that therapy, then I think it's absolutely important to consider the role of PARP maintenance. And I do use a biomarker-driven strategy to try to help inform patients about what they might anticipate for benefit. So BRCA1 testing and HRD are critical. In patients who aren't receiving bev, the PRIMA trial is probably the most, applicable. And as you know, that showed some benefit to all comers, but the magnitude of benefit depended greatly on what the integrity of their, DNA repair mechanisms were. So I think that having that information up front helps you inform your patient, and you can together make better decisions. In the setting of someone who's like this, who's on bevacizumab, then the partner, if you're going to contemplate a PARP, I think in that situation it needs to be olaparib, because at the moment we don't have data of niraparib plus bev, although we will have that very soon with the first trial. But there was no benefit to patients who didn't have an HRD, to the combination of olaparib plus Bev. So that, I think in that setting, it would be very informative as well.
Dr. Yan, what is your approach to these advanced ovarian cancer upfront PARP maintenance?
Yeah, for upfront and actually, you know, for BAV, and it's always upfront discussion if you want to do that or not. And if you look at all the data, you know, the data is not impressive, and typically upfront first-line treatment, you know, it's always a careful discussion, and especially for those patients presented with ascites, probably I'm a little bit kind of more lenient towards that. Because the data is slightly better that way. But, you know, regardless, you know, upfront, the data is not super impressive. BAF in general can be good, but, you know, Dr. Drescher probably know one of my patients, nephrotic syndrome, acute renal failure, and, you know, I cannot even give her any other anti-cancer treatment. It's not super benign and it can cause harm. So especially when the benefit is not a whole lot, you know, I'm hesitant to give that upfront. But, you know, I do feel upfront, if especially it's of advanced stage, and I do feel more strong to check the somatic mutation, look for HRD. In that way, I can put them on PARP inhibitor. Because, you know, if you look at the SOLO-1 data, the data is impressive that way. So, you know, I know the data of BAF and PARP inhibitor is coming, and it's going to be more confusing. But for now, I would put the patient on PARP inhibitor if I have the BRCA or the HRD. Otherwise, you know, they can do very well for quite some years.
Yeah. Sounds good. Yeah, that's kind of.
Can I make a comment?
Sure, Dr. Nag.
So I think in the end, you've got to figure out what is clinically meaningful in terms of PFS. So if you're going to look at a 2 and a 3 month PFS, it's really not that important. It's that 6 month PFS that I personally look for to be able to offer such a treatment to my patient. And when you are doing a combination of BEV and a PARP inhibitor, you are getting 2 toxicities. So I think you've got to be very mindful of that as well. So these are the 2 things I would think about. And Dr. Drescher, just a quick question for you. What if she had been BRCA positive and we'd been giving her bevacizumab? Would you then switch as per SOLO-1 to olaparib? Or would you go with the Paula-1 data and just add olaparib to the bev?
Yeah, it's an interesting question. You know, it's not something that to answer your question, I would probably add the olaparib and see how she tolerated her treatment. And if we were running into toxicities, I would drop the Bev first and try to continue on with the olaparib. I did want to just comment. So we don't use Bev. I don't use Bev much in the frontline setting because, you know, it's again only improvements PFS, and it's been
3-4 months.
Been pretty marginal. There are toxicities and, you know, the inconvenience of having come back. There may be some selective high-risk populations for which we might consider suboptimal debulking, or someone who has a lot of ascites or pleural effusions, which might be, you know, driven by the VEGF pathway. But it's not a large proportion of the advanced stage patients who are receiving bevacizumab maintenance. And I just want to comment on the chemotherapy box. I would say that maintenance chemotherapy for ovarian cancer is not, you know, that's been considered in the past, and there's been a number of studies, and it's not panned out. So it's not an option that we would generally consider.
Perfect, thank you. Yep, agree. Our practice as well is we don't typically use Bev frontline. We use carbo and Taxol, but Bev sometimes in patients who have significant ascites, and if you're thinking maybe that will help. And the PARP inhibitor maintenance as well is the same strategy as biomarker-based strategy. Only consider it if somebody is BRCA1/2 positive or HRD positive. But again, the data, we'll look at that a little bit and see. Okay, so we talked about this, and then somebody did ask from Dr. And I think Dr. Nag answered, if you decide to only use BEV maintenance, how long would you consider? And Dr. Nag said 15 months. Okay, so let's talk a little bit about PARP inhibitors. So basically, I think what is important to understand how PARP inhibitors work is, there is a lot of off-target effects, which we'll not talk about, but the main mechanism is that when you have defects in DNA repair, which your main mechanism for DNA repair is homologous recombination. And if you have germline mutations in BRCA1 or 2, then basically you are not able to perform homologous recombination. Now, the sort of backup pathway then is non-homologous end joining, where PARP is one of the major enzymes in trying to repair the DNA. Now, in somebody who has BRCA1/2, who has homologous recombination defect, and you block the PARP as well, then there is really no way for the cell to sort of repair itself. And that's what leads to cell death. So in cancer cells, basically you're blocking, because of their BRCA1 and 2, you are now using sort of blocking their backup pathway for repair as well, and then you're causing cell death. But that's just in BRCA1 and 2, and we know that there is some activity of PARP inhibitors outside of this as well, and those are some of the off-target effects. So if you look at the maintenance olaparib data in newly diagnosed advanced ovarian cancer, this is the SOLO-1 study which did demonstrate that this is which did demonstrate that olaparib plus bevacizumab was better than placebo plus bevacizumab in terms of PFS. And if you look at the hazard ratio, it was 0.59. But what was very important, and I think this is what Dr. Drescher was earlier referring to, is if you look at where the advantage was, if you look at this is the hazard ratio of 1. BRCA mutation carriers obviously tend to do better. And the second group over here is no BRCA mutation or unknown was there. But if you look at tumor HRD status, those who were HRD positive, they tended to do better. But for HRD negative or HRD unknown, the hazard ratios did cross 1. And I think that's what we most of us look at, and we say, well, do we really benefit? So does somebody really benefit if they have, they do not have HRD? And so I think a lot of the practices are still sort of using a biomarker-based strategy to decide on upfront maintenance therapy. Now, this is the SOLO-1 data where they looked at olaparib versus placebo, which also demonstrated progression-free survival benefit. Now, this is just PARP maintenance. This is not without. This is not with BEV. And this one, the majority of patients did have BRCA1/2 mutation, and the rest did not. In the SOLO-1, they did not really clarify based on the non-BRCA1/2. So I think the Dr. Ramesh Drescher had asked a question over here, and which I think we should go to and is relevant to what I'm going to talk about. What is the choice of samples for looking for genetic mutations? Surgical specimen followed by blood, or directly to blood samples, directly to decide maintenance therapy? So I guess the question is, how do you, when you're looking for biomarker-based strategy, how do you choose your samples? Do you start with the germline BRCA1/2 and then go for HRD testing in the tumor, which is kind of our strategy at Mayo Clinic? Is we typically do germline-based testing first, and if they are negative, then we do HRD testing on the tumor sample. But I guess I would like to know from Dr. Yan, what is your strategy? How do you approach looking for biomarkers?
Oh, we are very similar. So we initially at diagnosis, we would have done a germline genetic tests anyway. And if it's negative, we do know there are about 10% of the patient, they may have somatic mutation. And those are the 10% we are looking for. So, for that, I typically start with the tumor specimen, look for the somatic mutation. For me, tissue is always important. So I always do that on the tissue.
Dr. Drescher, Dr. Nag, what is your approach to this?
Our approach in general, I guess I'll go first, is to focus actually on the tissue because, it's readily available. It doesn't, we can move forward with that without having to, address all of the issues associated with germline testing, which can, be which needs to be done, but can be complicated. We're actually, and then in addition, you'll get a lot of information from the tumor, which, as we've discussed, can inform lots of decisions with respect to treatment that you cannot get in the germline. And those would include things such as genomic instability, LOH. We'll get to look for tumor mutational burden and things that might be relevant, and targets that might be relevant downstream for time of relapse. So we focus on the tumor first, and we've tried to build in the process of building in reflex testing protocols. So given a particular diagnosis, your tumor tissue is automatically sent for next-gen sequencing. And the turnaround times, we're looking for that is usually in the range of about 3 to 4 weeks from diagnosis. And then I guess the final comment about tumor first is that it can help you inform potentially what to look for in the germline, and you may be able to do, do a more targeted testing in the germline. So our approach generally has been tumor first, germline second.
Any additional comments, Dr. Nag?
No, so I've been doing germline so far, but there's a very strong rationale, and I agree with Dr. Drescher, that if you have good tumor tissue, it makes sense to do that, because a couple of times I have sent the tumor in and I've got a phone call saying, hey, there's a very likelihood of a P53 germline here, please send the blood. So you can get more information probably from the tissue, as he said. So I may change my strategy. I'm thinking about that.
Perfect, thank you. So when we think of, we had talked about germline testing, and when we think of a homologous recombination defect, I mean, obviously germline mutation can give you a homologous recombination defect in the tumor as well. But there are other things that can give you HRD as well, and so it's things like promoter methylation. And then there is, some tumors just have HRD, and we don't know what really led to HRD. So I think BRCA1/2 testing and HRD testing are complementary in many ways, because we know that these tumors that do have HRD do respond to PARP inhibitors. And HRD testing methods includes really looking for multiple things. So things like loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions. That's what really the test is trying to do, to look for HRDs. And these are really markers of genomic scars, so which tells you whether there is HRD or not. And tests have come up that have sort of assigned a score to each of these, and then come up with a final score and saying whether the tumor has HRD or not. And then, so we had talked about HRD as being a biomarker-based strategy, so I think we will move on to this. The patient does not want to do, there was a discussion, and then there was no HRD performed at that time. The patient did not want to do maintenance therapy regardless, so that there was no HRD testing performed. But 2 years after diagnosis, he presents again with ascites and recurrent disease, which we know these patients tend to. And this time CA125 is over 300, again undergoes 6 cycles of carbo and taxol. This time she did not want to do Bev either, and achieves NED, CA125 is normal. And this is the question that comes up in the recurrent setting, where somebody is platinum sensitive, would you do PARP inhibitor? And I think we can look at some of the data, which I think would be informative for our discussion is, so olaparib, if you look at the data, olaparib compared to placebo after, in the recurrent setting, platinum sensitive setting, did improve PFS. But if you look at where the PFS benefit truly was, it was in patients with BRCA mutation. You look at this curve, and in patients with wild-type BRCA, the curves aren't that impressive. So I think that's something to be said. Same thing with niraparib as well. If you look at germline BRCA mutation, you see that the curves are wide. No germline BRCA mutation with HRD positivity, you see that there is a PFS advantage. But when you look at no germline BRCA mutation at all, the curves tend to be, the benefit does not seem to be as significant. Rucaparib, same thing. I think basically with all of these, I think we know that the benefit tends to be more so for BRCA1/2 mutation carrier or those with HRD positivity. But I think at this point, because if you probably don't do PARP now, PARP is probably not an option for this patient ever. So do you even look for HRD at this point, or would you offer PARP regardless? And so let's talk about that a little bit. Dr. Dresser, I'll go to you first.
Yeah, it's a really Interesting question. I think there are a lot of things to consider. I think the first thing to consider is, unfortunately at this point, because the patient has recurred, I usually inform them that their disease is unlikely to be curable. And so we're really focusing on palliative care, symptom management. Another thing I think that weighs into this discussion is what was the original PFS? Because we know kind of historically that the next PFS is going to be roughly the same length or perhaps shorter. So that can help inform you about, what the kind of challenge that's facing you. If you have a short PFS, then you're relatively short, then you're concerned that, you're going to have symptomatic recurrence in a relatively short period of time, and consequently maintenance to delay that may be of more benefit. And I do think, again, as in the upfront setting, having HRD information is useful to try to help inform these types of decisions. So I don't think there's a right or wrong in this setting, and you need to kind of consider all the factors. But specifically to the question, I would encourage and try to get HRD. There's an issue about, if you had more recent tumor, it's probably better to get that than to use the primary tumor, just because there's evidence that that score can change with chemotherapy. So those are kind of the issues that I would consider in a situation like this.
Dr. Nag, what would you do in this situation?
So I'm interested to know, if we get a fresh piece of tissue, would we be checking for BRCA again? Could this patient have acquired a BRCA mutation, a somatic BRCA mutation?
Dr. Drescher, I'll let you answer that question.
Yeah, I think it's possible. I would do the whole panel again. Right. I think more frequently what you might observe, what's been described as reversion. So patients would start, but I think it's at least theoretically possible. So I wouldn't just send, and I don't think you can just test for genomic instability. You usually get the whole panel plus. So that's like a plus test. Yeah.
Right.
Dr.
Yeah.
Yan.
So I think I would do that, and then, this would probably be one of your last chances to use a PARP, and you might, if she's certainly biomarker positive, I would definitely use a PARP inhibitor.
Gotcha. Dr. Yan, at this point, do you again use a biomarker-based strategy, or would you still consider doing a PARP regardless of biomarkers? So let's say even if she is BRCA1/2 negative, HRD negative, would you still consider PARPs?
Yeah, I would still consider, because even for the HRD negative and the BRCA wild type, you still have somewhat benefit, even it's not as dramatic as the one with the mutations and HRD positive. And this is the chance we use that. But get back to, would I always get a new genomic test? Not necessary, because I'm not sure if that that gives me more information, but I'm not 100% sure that will change my management. So depending on the scenario, I potentially may get a new test, but not necessarily always.
Yeah, and I think that's kind of our practice as well, is to offer PARP, but be understanding of the fact that if there is no HRD, no BRCA1/2, then the benefit might not be as much. All right, so I think briefly, I think we are towards the end and we are already over the time. Briefly, role for, so we talked a lot about germline genetic testing, but we did not talk quite about NGS and PD-L1 testing. And is there any role of doing NGS in ovarian cancer? And I think I just want to present a little bit about the TCGA data, which showed that, out of 316 patients, almost 96% had TP53 mutations. And then there was like BRCA1, and this is all in tumor. These are whole exome sequencing of tumors, and BRCA1, and then a bunch of others. But really, if you look at this, there really isn't much that you could target with NGS. Even if you did NGS, they're untargeted drugs. So is there any value in doing NGS in ovarian cancer patients? And if so, what subgroup of patients, and when would you order that? Let's start with you, Dr. Drescher, again.
Yeah, I mean, there's no right or wrong answer here, and this is obviously very accurate data. And high-grade serous cancers, there's just very few recurrent and targetable mutations. So it has limited benefit. Also for, you can look at other markers like tumor mutational burden. And as you mentioned, PD-L1 immunoscores, immunostaining, to try to help, I would say, target people towards the clinical trials. I think that next generation sequencing is potentially more beneficial for the other histologic subtypes, where you see a different spectrum of mutations, some of which are potentially targetable, and in particular, thinking about things that might be mismatch repair genes or RAS, RAF pathway genes. So I do think there's potential benefit. Most of it resides on identifying patients who might be candidates for trials. There is some conventional therapies for which it could be informative, but most of that would be in the non-serous histologies.
Dr. Yan, any thoughts on this?
Yeah, and we do have quite some drug approved regardless the tumor type and purely on the genetic mutation, but I don't remember I see much in ovarian cancer. Ovarian cancer just don't have too much targetable lesions, and yeah, and we do have some clinical trials available too, but rarely ovarian cancer we can find a meaningful target and target that. But we always want to look for that though.
Dr. Nag, you did mention the endometrioid histology as well, which is interesting because those are associated more with the Lens syndrome and probably have some benefit.
Absolutely,
in doing
and
those
there
systems.
I would definitely do an MSI, and probably opt for an NGS as well. But in ovarian, I usually don't. I don't do NGS testing.
Gotcha. Perfect. Thank you. So let's move on to basically last word on Keynote 100. Immunotherapy in ovarian cancer. I mean, when I look at this data, I was very disappointed. I don't know about, so I'll let you guys comment on this. I mean, should we even be testing? Because, the data with Pembro is just so disappointing that I don't even feel strongly about testing, but I'll let you answer this. Dr. Nag, Dr. Yan, or Dr. Drescher, anybody could take it first.
Yeah, so how about the combination? Because, I was super disappointed because, I treated breast cancer 90%. The Keynote 522 was so impressive that I'm putting everyone on Keytruda now for triple negative breast cancer. This is super disappointing, but, I'm not sure if this is, this is what we would do. And if you look at Keynote 162 and Mediona, and actually combination of checkpoint inhibitor and PARP inhibitor, the data looks very impressive, actually. The response rate was over 60%. The data looks very promising. So
very small studies.
Yeah, but yeah, I know it's only 60 patients, just small studies, but I think it makes sense. And I do not want to tell myself that immunotherapy checkpoint inhibitors does not work in ovarian cancer. I don't think we're there yet. We just don't know enough yet.
Dr. Nag?
No, I don't think we're going to get anywhere. I think we've got the jackpot with PARP. We need to stick with what we know and find perhaps better ways of doing HRD testing and widening the net there. I don't think ovarian cancers are really immunogenic. So I don't think we're going to get very far.
Dr. Drescher?
Yeah, I think from a clinical perspective, currently there's not a lot to offer, but I wouldn't say that there's not hope for the future. No, the ovarian cancer is generally not super immunogenic, as you say. I mean, if you look at the number of, if you look at predicting algorithms and try to look at the number of either tumor mutational burden or the number of potentially targeted neoepitopes, it's definitely in the intermediate group. And then you're kind of confronted by the fact that the microenvironment for most high-grade serous cancers is often highly immunosuppressive. So there are kind of a lot of barriers that need to be overcome. And so like a single approach, with a checkpoint inhibitors not going to solve it.
Yeah.
But that doesn't mean that, there's not opportunities with, like, for example, a lot of areas that we've been thinking about, which I think will be potentially beneficial, is using multi-antigen vaccines in the setting of someone who's achieved a CR. So that might be a strategy that works. There's people obviously who are looking at, adoptive T cell therapies,
Right.
either alone or in combination with immune therapies. And then, I think there's still a role that are being explored for combination checkpoint inhibition in addition to PARPs and other agents. So yeah, it's not been, it's certainly been a disappointing scenario so far.
Okay, so with that, I think we have come to the end of our talk today. I think we talked about a little bit about epidemiology of ovarian cancer. We discussed some of the common molecular abnormalities, which is not much. I mean, it's mostly focused towards PARP and germline BRCA1/2 or tumor BRCA1/2 and HRD. And then we talked about the role of PARP inhibitor in early stage, upfront, and recurrent settings. And I think hopefully this was helpful to all of you. And with that, I'll end the talk and see if there are any questions. We'll try to answer those.
So I have one question. There is one mutation, this happens in 1% of time, NTRK gene mutation, somatic mutation.
Track.
And there is one or two targeted therapies. So I just wanted to have an opinion of the panel. Is it one of the options you would consider in some cases?
So I guess the question would be, how often do we even see those mutations, the NTRK fusions in ovarian cancer? I have personally not had a single case with NTRK, but I'll let the panel answer this.
Yeah, I have not either. I'm not an expert in that particular target, but I think you raise a valid point about there's certainly a difference between having a mutation in that gene versus having a fusion that's targetable.
Dr. Yan or Dr. Nag, any comments on that?
I haven't had a chance to find these mutations.
But that said, if it was there, I would definitely target it.
If you found it, I definitely want to put them on the hand, but I personally don't have. But if you look at the data, it's not 0%. Yeah. So, we just have not encountered those patients yet.
Yeah, it's probably not the common ones, and it's just might be one rare patient here and there, but I guess it is probably still makes sense to look for it, and that's where the NGS and other things might still be important in because you might find that there might be one patient out of your 100 or 200 cases where that drug might benefit that patient, I guess. And
yeah, I guess I would add, but that is the real power of this sort of panel testing, right? To personalize your care. So if you get that one off, that's where you want to be.
Yeah.
Yeah, actually, it's interesting in lung cancer, for example, ALK and ROS1, they have found only 1% and 2% time, but if it happens, there is a very good targeted therapy. So I think this is the promise, they might be infrequent, but if you have a very effective therapy, then is perhaps, when we are doing testing, it comes on the top of the panel for ovarian, perhaps it will be, it will be beneficial to look at.
Yep, definitely. All right, any other questions? If not, thank you very much. I would like to thank Dr. Drescher, Dr. Nag, and Dr. Yan for joining us today. This was really very informative, and thank you for an awesome excellent discussion. I'll give the floor back to Dr. Shah.
Well, thank you, Sid. As always, outstanding job in moderating and presenting the data. And very thankful to Dr. Drescher, Dr. Yan, and Dr. Nag for outstanding discussion. And of course, thankful to audience for excellent questions and making this session interactive and worthwhile. And all this meeting is going to be recorded. It's already recorded, so it is going to be on our website. And if you have, if you want to watch it later, or if you want to share this with another colleague, you're welcome to do that.